Hello, I'm Cody Sasek, Chief Clinical Director for the Creighton University School of Medicine PA program here in Omaha. I'd like to take a few moments to share a bit today about entrustable professional activities and competency-based medical education, particularly focused on that assessment piece. This has been an interest of mine and was also the focus of my PhD dissertation. I've been fortunate to be able to attend Kate's International Conference on the Ins and Outs of EPAs, and I think there's some really important things to consider in how we assess our clinical learners. So let's get started with a bit of background. All right, let's take a look at the setting and background in which the development and implementation of EPAs occurs. As you know, all stakeholders, all healthcare stakeholders have a real vested interest in the outcomes of the work that we do in training healthcare professionals. Current pressures include a focus on outcomes, demonstrable outcomes, accountability of programs and educators, and a learner-centeredness of our education and training. And all of that occurs while trying to develop and guide competency development and demonstrate and ensure competency outcomes for our learners. And so in attaining those milestones, there are questions about how we do that in a competency-based education model. I think it's important to consider some of the background and challenges that have led to the development of entrustable professional activities. The scrutiny of assessment and competency-based medical education is the result of several factors. Many educators consider competencies too broad and too theoretical to be effectively translated into traditional scale-based assessment instruments used within the complex and contextual world of medical practice. For example, patient care is defined as a competency domain in many CBME curricula. When a relatively abstract general concept such as patient care is considered a competency without a relevant context or greater specificity, it becomes difficult for both learner and evaluator to conceptualize and assess its outcomes specifically, as patient care has many facets and interpretations. Without a more specific and authentic assessment model, ambiguities and variability in a learner's demonstration of competence across medical specialties and settings has become problematic. When the student and/or evaluator are unclear of what is to be assessed in making judgment of competence, there exists an inherent problem of practice. This problem also extends to the designing of evaluation instruments. Assessment models such as entrustable professional activities seek to translate broad, general competencies into more specific, authentic clinical activities. There's also some concern that the generally established core competency domains do not transfer to the care of patients. Opponents of current models argue these frameworks, such as the ACGME milestones framework in the US or the CanMed's Canadian equivalent, with their broad nature, do not fully capture or focus on the ultimate desired performance outcome we're looking for, which is how clinical performance translates to the care of actual patients. Another concern is the lack of integration across competency domains in scale-based assessments. Individual competency domains rarely, if ever, stand alone in clinical practice. Furthermore, the mastery of individual competency domains does not guarantee the ability to integrate this competence holistically across domains or to apply them to patient care in an appropriate manner. Competent medical practice requires a complete complement of competency domains. Of course, in terms of safety and efficacy, it is insufficient for a healthcare provider to be competent in several areas of the competency domains while demonstrating incompetence in others or lacking the ability to integrate competence across various domains and contexts. As we know, the parts or abilities within individual competency domains do not add up to the entirety of authentic clinical practice. The focus on objective, measurable evaluation of learner abilities may also distract from the more accurate but nuanced assessment of how learners care for their patients in a dynamic workplace environment where the demands professionals face are to some extent always unique. Models of assessment in CBME have the challenge of both improving competence as well as identifying incompetence. Persistent issues with the evaluation of academic and clinical outcomes in health profession students have been noted. It's particularly true in the clinical setting, as we know, where evaluation has generally been based on a supervisor's subjective judgment of the overall performance of a student. This process is reductionist, attempting to extract overall competency domain assessment data from multiple varied patient encounters. The resulting rater variability, as well as differences in the instruments developed by medical education programs, have led to difficulty assessing competence in a CBME model with reliability and validity. A systematic literature review by Lori Mooney and Linus in 2009 found no evaluation instruments that validly assess competency of medical learners in a clinical setting. Clearly a problem, and this is the result of what is found in the literature that demonstrates psychometric issues associated with traditional scale-based clinical evaluation models. These weaknesses include poor validity and reliability, as well as scale range restriction, poor discrimination between learners' performance levels, and several others. Assessment of performance in the clinical learning environment is complex. Performance assessment is a judgment and decision-making process in which rating outcomes are influenced by interactions between individuals and the social context in which the assessment occurs. Assessment of learners in the clinical setting almost always involves single trainees, single assessors, and unique context. Lori, in 2012, noted that more than 2 decades of work, however, have not produced a widespread consensus on how to define these competencies, let alone on how to assess them. Because of the challenges in operationalizing CBME assessment, along with increasing calls for accountability and demonstration that graduates of training programs are prepared for a dynamic healthcare environment, CBME and the ability to clinically assess competence has been a topic of much discussion and increased scrutiny. The goal here is to give us an assessment system that's integrated across a variety of clinical situations and during actual clinical performance, and that results in actionable outcomes data that's both reliable and valid. In summarizing these challenges, which I'm sure you all are all keenly aware of, I and others might argue that behavioral objectives or competencies cannot fully describe complex human behavior in a complex environment. As you know, the sum of what professionals do is far greater than any of the parts that can be described succinctly in competency terms. Tushi and Tenkate state it well when they note that even a simple activity, such as taking a history, illustrates how inextricably communication, professionalism, medical knowledge, and clinical reasoning skills are integrated tightly within a conversation with the patient. They went on further to contend that assessing any competency individually is meaningless, whereas assessing a task as a whole within a context is sensible and also more authentic. Despite the promise of CBME, its complexities have led to both practical and psychometric limitations. As health profession educators seek to assess competence with reliability and validity, these factors have led in part to the development of novel assessment models such as Entrustable professional activities. Building on this concept, EPAs are defined as units of authentic professional practice, which might be something like gathering a history and performing a physical exam, that can be entrusted to a trainee once he or she has demonstrated the ability to consistently and effectively perform them to the supervisor's satisfaction. Specific EPA tasks are a combination of multiple competency domains such as medical knowledge, communication skills, professionalism, etc. To synthesize these domains and complete the EPA satisfactorily, the integration of knowledge, skills, and attitudes is required. Learner factors also play a role in entrustment. These learner factors include knowledge, experience, attitude, and discernment and insight into limitations. EPAs are specifically carried out in the delivery of patient care and as such are observable in both their process and their outcome. As a result, EPAs help to bridge the gap between competency-driven education and clinical practice and can provide a more realistic mechanism for assessment of competence than other competency-based models. Additionally, beyond specific learner performance, entrustment decisions are also based on evidence that students know their limitations, can be relied on to follow through, and are forthcoming despite potential personal costs, in addition to having the requisite knowledge and skills. EPA-based assessment is grounded in the level of trust an evaluator has in a trainee to perform specific activities independently on a scale that moves from no trust to perform to complete trust, allowing for independence. Said another way, an EPA takes the development of trust and explicitly codifies it using competency and milestone language. EPA assessment frameworks guide the gestalt of supervisors so they can support the provision of effective assessment and feedback. Entrustment requires an evaluator to make a judgment that integrates learner performance with assessor expectations and the nature of the EPA or task. As such, EPAs offer enormous practical value because it captures the assessor's overall judgment in the context of an important professional criterion. Is the learner trustworthy to do this task independently? Something certainly we deal with at all levels of education, including GME. The complexities of CBME competencies do not typically lend themselves well to traditional standardized psychometrics. Because of this, much effort has been focused on making systematic the more subjective judgments of evaluators. Early studies have found EPA construct-aligned methods to show favorable validity evidence. Assessment tools based on EPAs also align with the developmental concepts of the Dreyfus and Dreyfus model for the development of expertise and with the Miller pyramid of competence. Additionally, research in Dutch PA programs has demonstrated the ability of EPAs to support a flexible, individualized, competency-based workplace curricula, potentially moving away from a time-based experience to one in which students and learners progress as their expertise and competence grows. Assessment with EPAs offers many advantages, but is not without disadvantages. Narrowing the number of EPAs to a complete but manageable list is difficult. Evaluators will naturally have varying degrees of propensity for trust. Because of possible variability in the granting of trust and the specificity of the context of entrustment decisions, multiple observations by multiple observers and the use of clinical competency committees are needed to make sense of the data and render summative decisions. Efforts must also be made to educate and train evaluators on the EPA assessment process. Here we see an example from our friends in pharmacy education, looking at how they've created milestones along the course of their curriculum with expectations on levels of trust, with a very early learner having low expectations for independent practice, and a postgraduate trainee having very high expectations for independent practice here. You see here the layering on of assessment activities with Miller's pyramid, and then those EPA levels of supervision, so that realistic expectations and clear expectations can be set for both the learner and the assessor. This example from the Association of Family Medicine Residency Directors shows how milestones can be incorporated with an EPA-based approach with an expected level of entrustment based at a certain point or milestone in their curriculum, shown here for several competencies and subcompetencies. So let me summarize this with a quote that I think fits well. Pangaro and Tancade in 2013 described effective competency assessment as a difficult task, certainly, and the community of medical educators is currently only at the beginning of finding answers to the many psychometric challenges it imposes. Now, certainly we know a lot more than in 2013, but there's still much more to know. Certainly when considering assessment strategies or use of EPAs, there's much to think about. And there's much also to continue to consider, both from the logistical operational aspects of EPA-based assessment and the administrative burden that can potentially result from the quantity of evaluations that are needed to be actionable and to make summative types of decisions. There's also more questions to know about the impact of entrustment, someone saying, I do trust you or I don't trust you, that interpersonal nature between the learner and the evaluator, the impacts there. And my research has looked specifically at the motivational impacts and the affective dimensions of learning and how that entrustment process can be impactful there. So I think there are some other considerations on the table as well. And so hopefully this provided a little bit of background and perspective on EPAs and where things are headed. Certainly if there are questions, I would welcome any emails or calls, and wish you all the best.